Hi everyone, a blessed day to all. So may God's guidance and protection be upon us. So this is our second topic for this week. So the physical examination of the cardiovascular system. So the cardiovascular system is made up of the heart and blood vessels. The main functions of this system are delivering oxygen and nutrients to the cells of the body, removing waste products, and maintaining perfusion to the organs and tissues. Before we proceed to our topic, let me present to you this disclaimer slide. So these are the learning objectives of this presentation. At the end of the topic, the student will be able to describe the structure and functions of the heart and the great blood vessels. Will be able to identify the landmarks and key auscultation sites of the precordium. Describe normal and extra heart sounds and their origin. Examine the jugular veins and carotid arteries of the neck. Inspect, palpate, and auscultate the precordium to evaluate the cardiovascular system. Discuss the risk factors for coronary heart disease, and finally, we'll be able to discuss risk reduction and create health promotion strategies to reduce coronary heart disease. So let us have a review of the anatomy of the cardiovascular system. So the cardiovascular system is again composed of the heart and blood vessels. And again, its main functions is to deliver oxygen and nutrients to the body cells. It also removes the waste products and maintains perfusion to organs and tissues. So the heart is a hollow muscular organ, a little larger than our fist. So it lies in the pericardial cavity in the mediastinum under the sternum and between the second and the fifth intercostal spaces. Okay. So about 2/3 of the heart lies to the left of the midline of the sternum. The area of the exterior chest that overlays the heart and the great vessels is called the precordium. So it is important for us to visualize the underlying structures of the heart as you examine the precordium. So you have to note that the heart is rotated so that the right ventricle occupies most of the anterior cardiac surface. So this chamber in the pulmonary artery is one from a wedge-shaped structure behind and to the left sternum outlined in black. So the inferior border of the heart or of the right ventricle lies at the junction of the sternum and at the xiphoid process. So the right ventricle narrows as it rises to meet the pulmonary artery, just below the sternal angle. Okay, so this is called the base of the heart and is located at the right and the left second intercostal spaces next to the sternum. So the left ventricle is just located behind the right ventricle and to the left. So it is outlined in black here. So it forms the left margin of the heart. Its tapered inferior tip is most often termed as the cardiac apex. So it is clinically important because it produced the apical impulse, which we identified during palpation of the precordium. So as the point of maximal impulse, or your PMI. So this impulse locates the left border of the heart and is normally found in the fifth intercostal space, 7 to 9 cm lateral to the mid-sternal line, or just medial to the left mid-clavicular line. The wall of the heart is composed of three layers. These are the pericardium, the myocardium, and the endocardium. So the pericardium is the outermost layer that is composed of two tough fibrous membranes that enclose and protect the heart. And we have the myocardium, which is the middle muscular layer that does the pumping, and the endocardium, or the inner smooth layer of endothelial tissue that lines the inner surface of the chambers and the valves of the heart. Okay, so let us now have a review of the cardiac chambers, valves, and the circulation. So the circulation of the heart is shown in this diagram. Okay, so the blood from the body organs and tissues, especially those from the upper extremities such as your head, neck, and etc., will return into the heart via the superior vena cava, while those from the lower extremities will return to the heart via inferior vena cava, and it empties into the right atrium and travels through the tricuspid valve into the right ventricle, which then pumps it through the pulmonary valve into the pulmonary artery, and it goes to the lungs for oxygenation. So after passage through the lungs, the blood returns, or the oxygenated blood returns to the left atrium. It passes through the pulmonary veins, okay, and it passes through mitral valve into the left ventricle. Then it is pumped into the aortic valve, into the aorta, for distribution of oxygenated blood throughout the body. Because of the positions, the tricuspid valve and the mitral valve are often called atrioventricular valves. So the aortic and the pulmonary valves are called semilunar valve because each of their leaflets is shaped like a half moon. Okay. So as the heart valves closes, the heart sounds arise from the vibrations emanating from the leaflets, the adjacent cardiac structures, and the flow of the blood. So the heart serves as a pump that generates varying pressures within its chamber as they contract and relax. So it is called systole, which is the period of ventricular contraction. So in this diagram, the pressure in the left ventricle rises from less than 5 mm per mercury in its resting state to a normal peak of 120 mm per mercury. So after the ventricle ejects much of its blood into the aorta, then the pressure levels off and starts to fall. It's now called a diastole, which is the period of ventricular relaxation. So here, the ventricular pressure falls below 5 mm mercury and the blood flows from the atrium to ventricle. During systole, the aortic valve is open, allowing the ejection of the blood from the left ventricle into the aorta. while the mitral valve is usually closed, preventing blood from regurgitation or leaking back of the blood into the left atrium. In contrast, during diastole, the aortic valve is closed, preventing regurgitation of blood from the aorta back to the left ventricle. So the mitral valve is open, allowing blood flow from the left atrium into the relaxed ventricle. So understanding the interrelationship of the pressure in the left atrium, left ventricle, and aorta together with the position and movement of the valves is fundamental to understanding the heart sounds. So trace the changes in pressures and sounds through one cardiac cycle. So during auscultation, the first and the second heart sounds define the duration of the systole and diastole. So during diastole, the pressure in the blood-filled left atrium slightly exceeds that in the relaxed left ventricle, and the blood flows from left atrium to the left ventricle across the open mitral valve. So just before the onset of the ventricular systole, atrial contraction or the atrial kick empties the left atrium and produces a slight pressure rise in both chambers. During diastole, the left ventricle starts to contract and ventricular pressure rapidly exceeds the left atrial pressure, shutting the mitral valve. Closure of the mitral valve produces the first heart sound called S1. As the left ventricle pressure continues to rise, it quickly exceeds the pressure in the aorta and forces the aortic valve to open. Normally, maximal left ventricular pressure corresponds to the systolic blood pressure. After the left ventricle ejects most of its blood, ventricular pressure begins to fall. When the left ventricular pressure drops below the aortic pressure, the aortic valve shuts. The aortic valve closure produces the second heart sound, the S2, and another diastole begins. In diastole, the left ventricular pressure continues to drop and falls below left atrial pressure. The mitral valve silently opens. An opening or a snap may be heard if the valve leaflet motion is restricted. So this one, the snap opening. So as in mitral stenosis. After the mitral valve opens, there is a period of early rapid ventricular filling, as the blood flows early in diastole from the left atrium to the left ventricle. So in the young children, a third heart sound, known as the S3, may be caused by a rapid deceleration of the column of the blood against the ventricular wall. On the other hand, in older adults, an S3 is sometimes termed as S3 gallop, which is usually indicates a pathologic change in ventricular compliance. Finally, although not often heard in healthy adults, the fourth heart sound, which is S4, marks the atrial contraction. So it immediately precedes the S1 of the next beat, and it also reflects a pathologic change in ventricular compliance. So compliance is the ease with which the heart muscles are relaxes as it fills with blood. So poor compliance produces a stiff ventricle with reduced ability to expand as it receives the blood. So, moving on to the splitting of the heart sounds, we have here split S2. This event occurs on the left side of the heart. However, similar changes are also occurring on the right side of the heart, involving the right atrium, the right ventricle, the tricuspid valve, the pulmonic valve, and the pulmonary artery. So the right ventricular and pulmonary arterial pressure are significantly lower than the corresponding pressure on the left side. So the right-sided events usually occur slightly later than those of the left. Instead of a single heart sound, there is two discernible sounds that may be heard. The first from the left-sided aortic valve closure, or the A2, and the second from the right-sided closure of the pulmonic valve, or the P2. So S2 and its components, the A2 and the P2, are caused by the closure of the aortic and the pulmonary valves. So during inspiration, the filling time of the right heart increases, thereby increasing the stroke volume and lengthening the duration of the right ventricle emptying compared to the left ventricle. So this delays closure of the pulmonic valve, or the P2, splitting S2 into its two audible components during expiration. So these two components fuse into a single sound, S2. So splitting S1, it has also two components, an earlier mitral and later the tricuspid sound. Wherein the mitral sound, its principal component is much louder, again reflecting the high pressures on the left side of the heart. Okay, so it is heard throughout the precordium and it is loudest at the cardiac apex. So softer tricuspid best at the lower left sternal border. So it does not vary with respiration. Okay, so moving on to heart murmurs. So heart murmurs are distinguishable from the heart sounds by their longer duration. So they attributed to turbulent blood flow and may be innocent, as with flow murmurs of the young adults, or diagnostic of valvular or congenital heart disease. A stenotic valve has an abnormally narrowed valvular orifice, as you can see in this picture, that obstructs the blood flow, as in aortic stenosis, and it causes a characteristic murmur. On the other hand, the valve that fails to fully close, as in aortic regurgitation or insufficiency, it allows blood to leak backward in a retrograde direction and again produces a regurgitant murmur. So looking at the relation of auscultatory findings to the chest wall. So the location of the chest wall, where the heart sounds and the murmurs are heard, help us to identify the valve or the chamber where they originate. So the sounds produced by the heart valves travels with the flow of the blood. So the sounds and the murmurs arising from the mitral valve are usually heard best at or around the cardiac apex. So those originating in the tricuspid valve are heard best at the lower left sternal border. So the murmurs arising from the pulmonic valve are usually heard in the second and the third intercostal spaces close to the sternum. But sometimes it may be heard at the higher or the lower levels, as you can see in this color yellow. Okay. Murmurs originating from the aortic valve may be heard anywhere from the right second intercostal spaces to the apex of the heart. So because these areas overlap as illustrated in this picture, so we really need to correlate auscultatory findings with other cardiac examination findings for us to identify the sounds and the murmurs accurately. Okay, so moving on to the conduction system of the heart. So an electrical conduction system of the heart stimulates and coordinates the contraction of the cardiac muscle. So each electrical impulse is initiated in the sinus node, a group of specialized cardiac cells that is located in the right atrium near the junction of the vena cava. So the sinus node acts as the cardiac pacemaker and automatically discharges an impulse about 60 to 100 times a minute. So this impulse travels through both the atria to the atrioventricular node, which is also a specialized group of cells located low in the atrial septum. So here, the impulse is delayed before passing down to the bundle of His and its branches to the ventricular myocardium. So the muscular contraction follows the first atria, then the ventricles. So the electrocardiogram or the ECG records these events. So the contraction of the cardiac smooth muscle produces an electrical activity, resulting in a series of waves on the ECG. So the ECG consists of 6 limb leads in the frontal plane and 6 chest or precordial leads in the transverse plane. So the electrical vectors signals approaching a lead cause a positive or upward deflection. Electrical vectors moving away from the lead cause a negative or downward deflection. So when the positive and negative vectors balance, okay, they are isoelectric, appearing as a straight line. So this slide just show the 12 leads resting ECG electrode placement. So this is where you have to place the ECG leads. So the components of the normal ECG and their duration are briefly summarized in this slide. But as a student, you need further instruction and practice to interpret recordings from the patient. There is also an additional video uploaded in your Canvas for you to understand more about ECG reading. So the normal sinus rhythm or NSR is used to describe a normal ECG transmission. So you have to note that the small P wave of atrial depolarization, the duration is up to 80 milliseconds. So the PR interval, okay, is usually lasts from 120 to 200 milliseconds. So the larger QRS, complex of ventricular depolarization up to 100 milliseconds. This consists of one or more of the following: the Q wave, which is the downward deflection from the septal depolarization; the R wave, which is an upward deflection from ventricular depolarization. On the other hand, the S wave, which is a downward deflection following an R wave. So a T wave of ventricular repolarization or recovery, duration relates to QRS. So the electrical impulse slightly precedes the myocardial contraction that it stimulates. So the relation of electrocardiographic waves to the cardiac cycle is again shown in this image. So the heart is a pump. So the left and the right ventricle pump blood into the systemic and pulmonary atrial trees. So the cardiac output, the volume of the blood is ejected from each ventricle in 1 minute, while the stroke volume refers to the volume of the blood ejected with each heartbeat. It consists of preload, myocardial contractility, and afterload. So when we say preload, this refers to the load that stretches the cardiac muscle before contraction. Myocardial contractility refers to the ability of the cardiac muscle when given a load to contract or shorten. Afterload refers to the degree of the vascular resistance to ventricular contraction. So in each contraction of the heart, the left ventricle ejects volume of blood into the aorta and onto the atrial tree. So the ensuing pressure waves move rapidly through the atrial system, where it is felt as an arterial pulse. Although the pressure wave travels quickly, many times faster than the blood itself, a palpable delay between ventricular contraction and peripheral pulses makes the pulses in the arms and the legs unsuitable for timing events in the cardiac cycle. So the blood pressure in the arterial system varies during the cardiac cycle, peaking in systole and falling to its lowest level during diastole. These are the levels that are measured with the blood pressure cuff or your sphygmomanometer. The difference between the systolic pressure and the diastolic pressure is the pulse pressure. So there are 4 factors influencing arterial pressure. Those are the left ventricular stroke volume, the extensibility of the aorta and the large arteries, the peripheral vascular resistance, particularly at the arteriolar level, volume of blood in the arterial system. So any changes of these 4 factors could alter the systolic pressure and the diastolic pressure or both. So the blood pressure levels fluctuate strikingly throughout any 24-hour period, varying with physical activity, emotional state, pain, noise, environmental temperature, use of coffee, tobacco, and other drugs, and even time of the day. Okay, so moving on to the jugular venous undulations. So, the oscillations visible in the internal jugular veins and often in the externals could reflect changing pressures within the right atrium. So, careful observations reveals that the undulating pulsations of the internal jugular vein and sometimes the externals are composed of 2 quick peaks, the A and the V, and 2 throws, the X and Y. Okay, so the jugular veins provide an important clinical index of the right heart pressures and the cardiac functions. The jugular venous pressure, or the JVP, reflects the atrial pressure, which in turn equals the central venous pressure and the right ventricular and diastolic pressure. So the JVP is best estimated from the right internal jugular vein, okay, which has more direct anatomic channels into the right atrium. Okay, So the right external jugular vein is also useful for estimating CVP or central venous pressure. So the JVP usually falls with loss of blood, and it increases with right or left heart failure, or if there is pulmonary hypertension or tricuspid stenosis and pericardial compression or tamponade. So to estimate the level of the jugular venous pressure, you have to find the highest point of oscillation in the internal jugular vein. So the point above which the external jugular vein appears collapse. Okay, so the JBP is measured in vertical distance above the sternal angle, which is the bony ridge adjacent to the second rib, where the manubrium joins the body of the sternum. So the visibility of the jugular veins varies by patient or patient's position due to gravity. So in this patient, so the pressure or in the internal jugular vein is elevated. Okay, so in position A, the head of the bed is raised to 30 degrees, but the JBP cannot be measured because the venous undulation is above the jaw. Okay, and then in position B, the head of the bed is raised to 60 degrees. Okay, so the top of the internal jugular vein is now visible. So the vertical distance from the sternal angle or the right atrium can be measured. Okay, in position C, the patient is upright or 90 degrees. Okay, so the veins are barely discernible above the clavicle, which makes the measurement impossible. Therefore, the best position is the position B. So you note the height of the venous pressure as measured from the sternal angle. So it's actually the same in all position. But of course, our ability to measure the height of the column of the venous pressure or the GVP differs according on how we position the patient. So here, the GBP measured 4 cm above the sternal angle or more than 9 cm above the right atrium, which is considered abnormal. So the techniques of measuring the GPP are actually described in your book on page 395 to 97. Okay, so let us now move on to the health history. Okay, as a student nurse, make sure to take note of the following common or concerning symptoms, such as chest pain or discomfort, pain or discomfort radiating to the neck, the left shoulder or arm and back. So arrhythmias or skip beats and palpitations, dyspnea or shortness of breath and cough. So also take note of the following: edema, nocturia, fatigue, cyanosis, and pallor. Okay, so moving on to the assessment of the cardiac symptoms. So you have to assess for chest pain. Remember that chest pain is one of the most serious and important symptoms and often signals angina pectoris, coronary artery disease, myocardial infarction, acute coronary syndrome. Okay, you have to start by, or your initial question should be broad. For example, do you have any pain or discomfort in your chest? Okay, and then you can move on to a more specific question such as, is the pain related to exertion? Blah, blah, blah. You can utilize your old card. Okay, then also check for palpitation or ask if the patient experienced palpitation or heart skipping, racing, fluttering, or pounding. Okay. You can also ask the client for dyspnea or shortness of breath, okay, which is also a common patient concern and may again represent dyspnea, orthopnea, or paroxysmal nocturnal dyspnea. So you may want or you may ask your client like this question: do you ever have difficulty breathing or shortness of breath? So when does it occur? Uh, what were you doing when you become or when you experience short breath? And so on. So assess for cough. Okay, cough can result from fluid leaking into the lungs, such as in heart failure. Okay, there could be fine crackles and rales. Okay, you can ask your client if do you ever have a cough? Can you describe your cough? Okay, do you cough up mucus? If yes, can you describe the mucus? Okay, so when does it occur? Okay, any particular of the day, and then you can continue again using your old card. Okay, you have to remember that left-sided heart failure can cause a fluid leak into the lungs. Okay, then again, there could be fine crackles and rales heard upon auscultation. So, assess for edema. Okay, edema refers to accumulation of excessive fluid in the extravascular interstitial space. So, you have to focus your questions on the location, okay, which part, on the feet, left or right, timing and setting of the swelling, okay, and another associated symptoms. So this can be due to dependent edema that appears in the lower part of the body, the feet and the lower legs, usually when sitting, or the sacrum when bedridden. So could be due to congestive heart disease or hypoalbuminemia. So check if there is nocturia or urination at the night, okay? Sometimes it is a dependent edema that is mobilized at night and returned to the kidneys for excretion during night when the patient is reclining. So you can ask your patient if she get up more than once during the night to urinate, or how many times in the night she or he urinate. So, assess for fatigue. Okay, fatigue is an overwhelming, sustained sense of exhaustion. So, parang madaling mapagod. This signals heart is not adequately supplying oxygen. So, you can ask your client if do you feel more tired than previously, or are you able to perform your usual activities without resting, and so on. So you may ask if the patient also has cyanosis or pallor, which indicates also poor oxygenation of the body. So you can ask your patient, have you ever noticed your facial skin or lips or fingers become blue or pale? How long did it last? And then continue asking using again your old card. Okay, now let's proceed to the past history. Okay, you can ask your client the following questions. Do you have a history of heart problems or heart disease, murmurs, congenital heart disease or defect, rheumatic fever, hypertension, elevated cholesterol or triglycerides? Do you have diabetes? Okay. Okay, for the family history, you can ask if there is any family history of the following: coronary artery disease, hypertension, sudden death younger than 60, stroke, diabetes, obesity. Okay, again, you can use your genogram. Okay, the information of the grandparents, aunts, uncles, and first cousins can be used as well. Okay, for the lifestyle habit, you can ask about the client's diet or nutrition or the typical diet, or if the client is a smoker, okay, alcoholic drinker, what about the exercise or the medications used, the prescribed and the over-the-counter drugs. Now let's proceed to physical examination. So it is important to prepare your patient. Of course, your patient should be comfortable and calm, and then you have to explain the procedure of what you're going to do. If you're going to touch, or every time you touch your patient, you have to inform your client of what you are doing. Examination gown should be open in the front, and then you should have to assess to an examining table. Cover with drape, expose only areas that you're going to assess, and then perform examination from patient's right side. Okay, ito yung technique natin that you have to start from right side. And then you utilize technique, the head-to-toe assessment in your IPPA technique. For the equipment, you need the following: the stethoscope with bell and diagram, sphygmomanometer, two 15 cm rulers, watch with second hand, and examination light for tangential lighting. Okay, for the blood pressure and heart rate, you have to review measurements recorded from general survey and vital signs. So you have to repeat if needed, and then you have to refer in your table 14.1 in your book. So as you are taking the patient's history, you have to inspect the face, you have to note for the color, okay, and its presence of orbital edema. Look also for cyanosis and pallor that may indicate a poor perfusion of oxygen. Orbital edema may indicate heart failure, and anxiety occurs during heart attacks. So for the physical examination of the great vessels of the neck, so we have the carotid artery pulse. Okay, the carotid artery pulse provides a valuable information about the cardiac function and is especially useful for detecting stenosis or insufficiency of the aortic valve. So you have to check for the amplitude and contour of the carotid pulse. So you have to place the patient in a lying down with the head of the bed elevated to about 30 degrees. And then first inspect the neck for carotid pulsations. This may be visible just medial to the sternocleidomastoid muscles. And then you can place your index finger and the middle fingers on the right carotid artery in the lower third of the neck. And then press posteriorly and feel for pulsation. So press just inside the medial border of a well-relaxed sternomastoid muscle. Okay, roughly at the level of the cricoid cartilage. So avoid pressing on the carotid sinus, which lies at the level of the top of the thyroid cartilage. Okay, for the left carotid artery, you have to use your right fingers. So never press both carotids at the same time because this may decrease blood flow to the brain and may induce syncope. So check for the amplitude of the pulse. This correlates reasonably well with the pulse pressure. However, the contour of the pulse wave, namely the speed of the upstroke and duration of its summit and the speed of the downstroke. So normally, the upstroke is brisk. It is smooth and rapid and follows the S1 almost immediately. So for the brachial artery, so it is used if carotid has obstruction, kinking, or thrills. So to assess the brachial artery, you have to use the index and the middle fingers to feel for the pulse just medial to the biceps and tendon. So the patient's arm should rest with the elbow extended and then the palm up. So with your free hand, you may need to flex the elbow to a varying degree to get the optimal muscular relaxation, as you can see in this picture. So to continue with the physical examination of the great vessels of the neck, okay, again, to check for the jugular venous pressure, the head of the bed should be elevated into 30 degrees. So, at the beginning of the assessment, you have to consider the patient's volume status and how high the head of the bed is when you are examining. Okay, so if the patient who are hypovolemic, the JVP may be low. So it's necessary to lower the head of the bed, sometimes even to 0 degree, to see the point of undulation best. For hypervolemic naman, okay, you may need to place your client in higher position, and then note the height of the head of bed in record. Okay, so the steps for assessing the jugular venous pressure can be found in your book on page 395. Okay, you have to remember that the venous pressure measured at greater than 3 centimeters, so ito yung pag-measure, no, is considered abnormal. So this is how you will measure it. So for the instruction, you can check your book. Okay, so to distinguish internal jugular undulations and carotid pulses, so we have here this table. So the internal jugular undulations is rarely palpable, while the carotid pulsation is palpable. So the internal jugular undulations is soft, biphasic, undulating quality, and usually 2 elevations and 2 throws per heartbeat. On the other hand, the carotid pulsations has a more vigorous thrust with a single upward component. Okay, the undulations eliminated by light pressure on the vein just above the sternal end of the clavicle, while the carotid pulsations not eliminated by this pressure. For the internal jugular undulations, the height of undulations changes with position, dropping as the patient becomes more upright, while the carotid pulsation, the height of pulsations unchanged by position. Okay, for the internal jugular undulations, the height of undulations usually falls with inspiration. So the height of pulsation not affected by inspiration in the carotid pulsation. So, if the heart failure is suspected from the patient history or physical examination, or if the JBP is elevated, you can perform the abdomino-jugular reflex, which is formerly known as hepato-jugular reflex. Okay? Wherein you have to position the patient into the supine with the head of the bed at the same angle used by your GBP examination. And you can use your right hand, can apply it firmly on the patient's right upper quadrant as seen in this picture, or middle abdomen for at least 10 seconds. So this maneuver forces the hepatic venous blood into the vena cava, thus elevating the venous blood volume and pressure. While you are applying pressure, you have to watch the patient's jugular vein level. So for the healthy person, it is able to pump the extra blood through the heart within a few seconds. So the jugular vein pressure will rise for a few seconds and then rapidly diminish to previous levels. So, for much of the cardiac examination, the patient should be placed in supine, okay, turning to left side, sitting and leaning forward, and then correlate your findings with jugular venous pressure and carotid pulse. Okay, so this table just shows the sequence of cardiac examination. Okay, so the first column refers to the patient position, and the second column is the examination. Okay, for example, for the supine with the head elevated 30 degrees, you have to inspect and palpate the precordium. For the second right and the left intercostal spaces, the right ventricle and the left ventricle, including the apical impulse, particularly the diameter, the location, amplitude, and duration. Okay, you can also auscultate the second right and left intercostal spaces along the left sternal border, down the left sternal border to the fourth and fifth interspaces, and across to the apex with the diaphragm, and then so on. In doing the physical examination of the cardiovascular system, we have to utilize the four cardinal techniques of examination, such as your IPPA. So first, inspection. So make sure to carefully inspect the anterior chest for the location of the apical impulse, or the point of maximal impulse, and the heaves over the precordium, which usually indicates increased ventricular movement. So using tangential light is important in doing your observation. And you can use palpation to confirm the characteristics of the apical impulse. So for palpation, you have to begin with general palpation of the chest wall. First, you have to palpate for hips or lifts using your finger pads, and then you hold them flat or obliquely on the body surface, and then you have to observe for ventricular impulses that may heave or lift your fingers. Okay, so you have to check for thrills that is formed by the turbulence of underlying murmurs by pressing the ball of your hand firmly on the chest wall. Okay. Be sure to assess the right ventricle by palpating the right ventricular area at the lower left sternal border or in the subxiphoid area. So the pulmonary artery in the left second intercostal space, and the aortic area on the right second intercostal space. Okay. So usually the thrills may accompany a loud, harsh, or numbling murmurs as in aortic stenosis, or in patent ductus arteriosus, or to those who have ventricular septal defect. So they are palpated more easily in the patient positions that accentuate the murmur. Okay, so the apical impulse represents the brief early pulsation of the left ventricle as it moves anteriorly during contraction and touches the chest wall. So you have to note that in most examinations of the apical impulse is the point of maximal impulse, or your PMI. However, some pathologic conditions may produce a pulsation that is more prominent than the apex beat, such as enlarged right ventricle, or a dilated pulmonary artery, or an aneurysm of the aorta. So, if you cannot identify the apical impulse with the patient in supine position, you can ask the patient to roll to left side, this is the left lateral decubitus position, and you have to palpate again using the palmar surface of your several fingers. If you cannot find the apical impulse, you can ask the patient to exhale fully and then stop breathing for a few seconds. So for the location of the apical impulse, try to assess the location with the patient supine, because the left lateral decubitus position usually displaces the apical impulse to the left. Locate 2 points, the intercostal space, usually the fifth or possibly the fourth, which give the vertical location, and the distance in centimeters from the mid-sternal line, okay, which gives the horizontal location. So for the diameter, you have to palpate the diameter of the apical impulse in the supine patient. It is usually measures less than 2.5 centimeter and occupies only in the intercostal space. It may be larger in the left lateral decubitus position. Okay, now proceeding with the amplitude, you have to observe for the following amplitude. Example, okay, you have to estimate the amplitude of the impulse. It is usually small and feels brisk and tapping. Okay, some young adults have an increased amplitude or hyperkinetic impulse, especially when they are excited or during or after exercise. However, its duration is normal. So, the increased amplitude may also reflect hyperthyroidism, severe anemia, or pressure overload of the left ventricle, especially to those who have aortic stenosis, or volume overload of the left ventricle, as in mitral regurgitation. For the duration, this is the most useful characteristic of the apical impulse for identifying hypertrophy of the left ventricle. So for you to assess the duration, you have to listen to the heart sounds as you feel the apical impulse, or you can watch the movement of your stethoscope as you listen to the apex. And then you have to estimate the proportion of the systole occupied by the apical impulse. So normally, it lasts through the first two-thirds of the systole and often less, but does not continue to the second heartbeat sound. So, a sustained low amplitude, or known as your hypokinetic impulse, may result from dilated cardiomegaly. Okay, the right ventricular area of the heart usually is located on the left sternal border in the third, fourth, and fifth intercostal spaces. So the patient should rest supine at 30 degrees, and then you have to place the tips of your curved fingers in the third, fourth, fifth intercostal spaces and try to feel the systolic impulse of the right ventricle. Again, you can ask the client or the patient to breathe out and then briefly stop breathing. That is to improve your observation. So if an impulse or heave is palpable, you have to assess its location, amplitude, and duration. So moving on to another technique of examining or doing the physical examination of the heart, we can use percussion. However, this is rarely used to estimate cardiac size. ECG, X-rays, and echocardiography provides more accurate measurements. Okay. However, palpation of the apical impulse can also provide a rough size estimate. When you cannot feel the apical impulse, however, percussion may be your only tool but may not be reliable. Okay, so another technique of doing the physical examination of the heart is through auscultation. So auscultation of the heart sounds and murmurs is an important skill of physical examination. So it is important for you to know your stethoscope, especially the parts of your stethoscope. It has two sides, the diaphragm and the bell, which are acoustically different. So the diaphragm is better for picking up the relatively high-pitched sounds such as your S1 and S2, the murmurs of the aortic and mitral regurgitation, and the pericardial friction rubs. You have to listen throughout the precordium with the diaphragm, pressing it firmly against the chest. On the other hand, the bell is more sensitive to the low-pitch sounds of S3 and S4. So you have to remember low, bell, low. So the bell is for the low-pitch sounds. So you have to apply the bell lightly with just enough pressure to produce an air seal with its full rim. And then you have to use the bell at the apex and then move medially along the lower sternal border. And then you have to rest the heel of your hand on the chest like a fulcrum. May help you to maintain light pressure. Okay, pressing the bell firmly on the chest makes it function more like a diaphragm by stretching the underlying skill. So low-pitched sounds such as S3 and S4 may disappear with this technique. Okay. So, inching your stethoscope. So in a quiet room, you have to listen to the heart with your stethoscope, starting at either the base or the apex of the heart. So each pattern is satisfactory. Some experts recommend starting at the apex and then inching to the base. Okay, you have to move the stethoscope from the point of maximal impulse medially to the left sternal border superiorly to the second intercostal space, then across the sternum to the second intercostal space at the right sternal border. Okay. Alternatively, you can start at the base, okay, and then you have to uh, inch your stethoscope to the apex with again your stethoscope in the right second intercostal space close to the sternum, and then you have to move along the left sternal border in each intercostal spaces from the second row, okay, and the fifth, okay, and then to the apex. Okay, the heart sounds and murmurs that originate in the four valves range widely. So you have to use anatomic location rather than the valve area to describe where the murmurs and the sounds are best heard. So the importance of timing S1 and S2. So regardless of the direction of your move of your stethoscope, you have to keep your left index and middle fingers on the right carotid artery in the lower third of the neck. Okay, to facilitate correct identification of S1 just before the carotid upstroke and the S2, which follows the carotid upstroke. Be sure to compare the relative intensities of the S1 and S2 as you move your stethoscope through the listening areas above. So you have to remember that at the base, S2 is louder than S1 and it may split with respiration. At the apex, the S1 is usually louder than S2 unless the PR interval is prolonged. So you have to be careful in noting the intensities of S1 and S2. You will confirm each of these sounds and thereby correctly identify systole. So the interval between the S1 and the S2 and the diastole, the interval between the S2 and the S1. So when you are listening for the extra heart sounds of S3 and S4 and to murmurs, timing systole and diastole is an absolute prerequisite to the correct identification of these events in the cardiac cycle. So make sure to listen to the entire precordium with the patient in supine. Okay, so we can use important maneuvers to listen to the heart sounds by asking the patient to roll partly onto the left side into the left lateral decubitus position, bringing the left ventricle close to the chest wall. Then you can place the bell of your stethoscope lightly on the apical impasse. This position accentuates or brings out a left-sided S3 and S4 and mitral murmurs, especially mitral stenosis. Otherwise, you may miss these important findings. Next, you can ask the patient to sit up and then lean forward, exhale completely, and then stop breathing in expiration, pressing the diaphragm of your stethoscope onto the chest. Listen along the left sternal border and at the apex, and you have to pause periodically so that the patient may breathe. So this position accentuates or brings out aortic murmurs. You may easily miss the soft diastolic murmur of aortic regurgitation unless you listen at this position. Okay, so these are the table of auscultatory sounds, the heart sounds and guides to auscultation. For the S1, you have to take note its intensity and any splitting. So normal splitting is detectable along the lower left sternal borders. For the S2, just note its intensity. For the split S2, make sure to listen for the splitting of the sound in the second and third left intercostal spaces. You can ask the patient again to breathe quietly and then slightly more deeply than normal. Does S2 split into these two components as it normally does? If not, ask the patient to breathe a little more deeply or sit up. Listen again. A thick chest wall may make the pulmonic component of S1 inaudible. So the width of split, how wide is the split? Is it normally quite narrow? Also take note for the timing of the split. Okay, when is the respiratory cycle? Do you hear the split? Is it normally heard late in inspiration? Okay, so does the slit disappear as a truth during exhalation? If not, listen again with the patient sitting up, intensity of the A2 and P2, and then compare the intensity of the two components, the A2 and the P2. A2 is usually louder. For the extra sounds in systole, such as ejection sounds, or systolic clicks, you have to note their location, timing, intensity, and pitch, and the effects of respiration of the sounds. For the extra sounds in the diastole, such as S3 and S4, or an opening snap, you have to note again the location, the timing, intensity, and pitch, and the effects of respiration on the sounds. And S3 or S4 in athletes is normal finding. The diastolic and systolic murmurs. Some murmurs are differentiated from the heart sounds by their longer duration. Okay, to have more information or more knowledge about the heart sounds, you can refer to the following table posted in the slide. Okay, so proceeding, in assessing or doing the physical examination of the heart, make sure to correctly identify heart murmurs. The tips, okay, for identifying heart murmurs are the following. Okay, time the murmur. So does it occur in systole or diastole? Locate where is it loudest. Okay, is it at the base or along the sternal border or at the apex? And then conduct any necessary maneuvers such as having the patient lean forward and exhale or turn to the left lateral decubitus position. Also determine for the shape of the murmur. For example, is it crescendo or becomes louder or decrescendo or becomes softer? Is it pansystolic? Yan. And then you have to grade the intensity of the murmur from 1 to 6. Okay? And then identify associated features such as the quality of the S1 and S2, the presence of extra sounds such as the S3, S4, or NOS, or the presence of additional murmurs. So you have to be sure to listen in a quiet room. Okay, to continue with our physical examination, we have the following findings. So mid-systolic murmurs, okay, usually begins after the S1 and stops before the S2. Okay, there is a brief gaps that are audible between the murmur and the heart sounds. All you have to do is to listen carefully for the gap just below the S2. So it is heard more easily, and if present, usually confirms the murmur as the mid-systolic murmur and not pansystolic. Okay. So pansystolic murmur or holosystolic starts with the S1, stops at the S2. So without a gap between murmur and the heart sound. So as you can see in this picture or in this illustration, pansystolic murmurs often occur with a regurgitant or backward flow across the atrioventricular valves. Okay, so another finding here is the late systolic murmur. It usually starts in the mid or late systole and persists up to S2. So this is the murmur of the mitral valve prolapse and is often, not always, preceded by a systolic click. Okay, for a diastolic murmurs, this may be early diastolic or mid diastolic or late diastolic. An early diastolic murmur starts immediately after the S2 without a discernible gap and then usually fades into silence just before the next S1. So the early diastolic murmur typically accompany regurgitant flow across incompetent semilunar valve. Okay. The mid-systolic murmur usually starts a short time after the S2. It may fade away as illustrated here, or maybe merge into a late diastolic murmur. Okay, you have to remember that mid-diastolic or pre-systolic murmurs reflect turbulent flow across the atrioventricular valves. Okay, the late diastolic or pre-systolic murmurs starts late in diastole and typically continues up to S1. Okay, so another findings, we have crescendo murmur, wherein the murmur grows louder. On the other hand, we have decrescendo murmur, wherein the murmur grows softer, as you can see in this illustration. So the early diastolic murmur of aortic regurgitation is an example of this. Okay, so we have another findings here, the crescendo decrescendo murmur, wherein there is wherein the murmur first rises in intensity and then falls. Okay, and then the mid-systolic murmur of aortic stenosis and innocent flow murmurs is an example. So we have here plateau murmur. It has the same intensity throughout. Okay, so an example is the pansystolic murmur of the mitral valve. Okay, so it is important to grade murmurs using the following 6-point scale, and then you have to note that grade 4 through grade 6 is or require the added presence of a palpable thrill. Okay, so the location of maximal intensity, okay, that is, you have to find the location where the murmur is heard in terms of intercostal space and its relation to the sternum, the apex or the mid-sternal, the mid-clavicular, or one of the axillary line. Okay, so for example, a murmur is best heard in the second right intercostal space, often originates at the or near the aortic valve. Okay, so another findings during your assessment, okay, possible findings. Peripheral edema. For peripheral edema, this may indicate a heart failure. So you have to carefully inspect the feet, the ankles, and the legs. Okay, and this can be covered. No, the peripheral edema is covered in chapter 15. So you have to integrate cardiovascular assessment. So remember that cardiovascular assessment requires more careful examination, and then you need to correctly identify and interpret the individual findings. You have to fit them together in a logical pattern and correlate your cardiac findings with the patient's complaints and the patient's blood pressure and heart rate, carotid upstroke, and jugular venous pressure. Okay, you have to put them together to form a hypothesis of the patient's complaint. Okay, in recording your findings, please take note of the following data for the structures of the heart or the location, okay, or the colors, the auscultations, the pulsations, and the heart sounds. You have to take note all of these details. So for health promotion, of course, as a part of your nursing responsibility is to give health teaching or to create a health promotion program for your client. So the following topics must be covered. Okay, so coronary heart disease, stroke prevention, hypertensive prevention and management, hyperlipidemia prevention and management. So your key roles as a nurse or as a nursing student, okay, and a future nurse, screening patients for disease and risk factors is one of your key roles. Teaching patients relationship of risk factors to disease, educating patients on lifestyle changes to reduce risk factors, encouraging the patients to adhere to healthy lifestyles and medical regimens to reduce the incidence of disease morbidity. Okay, for the blood pressure classification for adults, okay, it is shown in this table. So for normal findings, okay, so less than 120 for a systolic, and less than 80 millimeter per mercury for diastolic. Okay. So, for risk reduction, especially for coronary heart disease risk factors, the following are the modifiable risk factors such as diabetes. Okay, why is it modifiable? It's of course, pwede naman meron tayong diet therapy for diabetes, systolic and or diastolic hypertension, increased cholesterol and or triglycerides, smoking, obesity, and physical inactivity. So all of this can be modified through exercise, through diet. Yan. Okay, again to continue with the risk reduction, okay, so we have here non-modifiable factors, meaning this is already given. So, wala na tayong magagawa. Especially for those who have increasing age, history of cardiovascular disease, and the family history of early heart disease. Okay. For hypertension, okay, risk factors, we have here modifiable risk factors such as obesity, physical inactivity, smoking, microalbuminuria, excess dietary sodium, insufficient intake of potassium, excess alcohol consumption. And again, of course, the following factors can be modified through exercise, diet, of course, teaching about smoking cessation, okay, teaching about or decreasing sodium intake, etc. So, for non-modifiable factors, so given na talaga as we age, so there is a very high risk of having different diseases such as hypertension, okay, the family history of hypertension or CVD or cerebrovascular disease. So to continue with the health promotion, okay, risk factors used to assess the 10-year coronary heart disease risk score are the following: age, gender, height, weight, waist circumference of or BMI, smoking, history of cardiovascular disease or diabetes. Okay, so you also assess for systolic and diastolic blood pressure, total cholesterol, the low density lipoprotein and the high density lipoprotein cholesterol, and the triglycerides, and the family history of early heart disease. Okay, so to continue with the risk factors and the screening frequency for adults beginning at 20 years. Okay, so this table shows the first column shows the risk factors and the second column shows the frequency of doing the screening. Okay, for those who have family history of coronary heart disease, it is important to update regularly. For those who are smoker, unhealthy on diet with alcohol intake, or the physical activities poor sedentary lifestyle, so screening should be done at each routine visit. For those with blood pressure, high blood pressure, or body mass index is not within normal, waist circumference, pulse, again to detect atrial fibrillation. So, screening must be done at each routine visit at least every 2 years. For those who have problem with the fasting lipoprotein profile, so every 5 years if low risk, and every 2 years if strong ang kanyang risk. For those may problem then or may findings sa kanyang fasting glucose or the hemoglobin A1C, so if the risk factors for hyperlipidemia or diabetes is present, so lagi din yung pag-i-screen. Okay, so to continue with the health promotion, so lifestyle modification to prevent or manage hypertension. So the following are recommended by the CDC, no? Maintenance of an optimal weight or BMI or body mass index of 18.5 to 24.9 is safer. Okay, and then salt intake of less than 6 grams of sodium chloride or 2,300 milligrams of sodium per day. However, individuals with hypertension, diabetes, or kidney disease, or those greater than or equal to 51 years, or those who are African American, should consume no more than 1,500 milligrams of sodium per day. So there should be a regular aerobic exercise such as brisk walking for at least 30 minutes per day, most days of the week. So moderate alcohol consumption per day of 2 drinks or fewer for men and 1 drink or fewer for women. Okay, dietary intake of more than 3,500 milligrams of potassium, and diet rich in fruits, vegetables, and low-fat dairy products with reduced content of saturated and total fat. So to continue with the lifestyle modification to prevent cardiovascular disease and stroke, there should be a complete cessation of smoking, optimal blood pressure control, healthy eating. Of course, you have to check the diet recommendations. No, you will learn this more in your nutrition and diet therapy when you reach your level 2. Lipid management, regular aerobic exercise, optimal weight, of course, dapat within the normal BMI. Diabetes management, so that the fasting glucose level is below 110 milligram per ml, and of course hemoglobin A1C is less than 7%. Conversion of atrial fibrillation to NSR, or if chronic, anticoagulation. So healthy eating. So, dapat healthy fat foods high in monosaturated fats lang yung ating intake. And then food that high in polyunsaturated fat and foods that high in omega-3 fatty acids. Okay. So, unhealthy foods, we should avoid foods high in trans fat, high in cholesterol, and high in saturated fats. Okay. So, to continue with our health promotion, okay, on counseling about weight and exercise, so dietary factors are associated with 4 of the 10 leading causes of death. So, you have to discuss principles of healthy eating, encourage exercising at least 30 minutes or most of days in a week. So, evaluate any cardiovascular, pulmonary, or musculoskeletal conditions before selecting an exercise regimen. Baka naman hindi rin kakayanin ng heart or ng pulmonary. So, that ends our topic on cardiovascular system, or the physical examination of the cardiovascular system. And again, this is our reference. Okay, so before ending this presentation, so let me again share to you these quotes from Caroline Javis. The character of a nurse is as important as the knowledge she possesses. So please take note, your character is very important. Okay? So thank you everyone for your time, and God bless you all.